Allergic rhinitis, I'm not going to talk too much about that, that's what we've done very well this morning. And I think that, yes, there's an association with allergic rhinitis and sleep impairment, but that's obviously the more moderate to severe group. The minor group, we're not that worried about. Use your steroids, use your antihistamines, and you'll improve their quality of life. Allergic rhinitis, it's said that there's an increased instance of allergic rhinitis in the OSA group, but is that really true, or is it a factor that actually nasal CPAP does induce inflammation in the first few weeks? You put somebody on CPAP in the first 2 weeks, they struggle because they feel nasally congested, but if you're ramping, should we say, 2 million litres through their nose at night in a year, that's quite a lot of challenge. And it does take a while for your nose to settle down. You might need humidification to actually improve on that, and that would help you. And using humidification can overcome some barriers, but you might need to give a short-term nasal decongestant, you might use some nasal steroids, or you might want to give antihistamines. So anything to do to improve nasal function so they can tolerate CPAP. Now, I've looked at some evidence that suggests, well, if you only operate on nose flow, let's say, so you get about 17% benefit. But I think we missed the point. The problem started in the nose, and it's had caused downstream effects in the palate, tongue, base, and pharynx. So if you only go back and correct the nose without doing the other bits, you're treating the initial cause, but you're not treating the consequences. So you're not going to get remarkable results. Also, as a surgeon, I would generally advise you avoid surgery if you can. Try something else first. Be sensible, be pragmatic. Remember, you have physicians you have to be impressed by how logical and sensible you are. You wouldn't do anything hazardous first off. You try medical management, you try CPAP, you try mandibular advancement devices, and in those cases that they're not responding, or in those cases that you feel that the airway resistance is so high from CPAP that they need nasal surgery, that's our role. Operating in appropriate cases, UPPs were done to death in the past and done on everybody. No rhyme or reason, and we ended up with rubbish results. As a specialism, we are rubbish at archiving our data. We are rubbish at producing good quality articles. It's just the facts of life. And if you have to be in this job for the next 20 years, you better find something that's a very good evidence base behind it, because it won't be paid for. I do 25 to 30 cases a year for OSA. About half of them are to facilitate delivery of CPAP. The other half are younger males, big tonsils, bed septums, nasal polyps, intolerant of CPAP, or it's not appropriate for them. Every patient is slightly different. If you can drop the airway resistance, you then increase the tolerance to CPAP. I don't know if everybody's actually tried a CPAP mask on their face. It's not sexy. It's not nice to wear. And if it's awkward, they will say, I don't want that. Expect to succeed in about 70% of cases in CPAP. You will fail in 30. In that 30, that's where we can come in with other strategies, other remedies, but keep it safe. Try them on something effective. There's no doubt about the evidence of what you're doing. And in your failures, that's when surgery and our skill as ENT surgeons comes into the fore. If you've got allergic rhinitis not been treated, you've got nasal polyps. There's so many things you can do medically to improve the nose before you proceed to surgery. If surgery has to be done, at least make it sensible and have a logic to it. This is a patient I operated on, lorry driver, HI 65. Bent septum, large polyps in his nose. He did have large tonsils as well. After surgery, dropped down to 15, maybe 16. He still needed CPAP therapy, but he's so much more comfortable on it. This is in pre-op. Pressures are riding very high, he's very disturbed, he was still snoring with CPAP on. You can see the post-op picture. Now this is an average because basically it's the same timeline as the patient, but during this period here, he could obviously immediately post-op, you can't wear their CPAP so well. So he broke for about 2 weeks and really went back. And all his parameters were much better. This guy's average pressure before surgery was 18. This is the difference between being comfortable. There's a log scale of discomfort. Going from a pressure of 13 to 14 is huge in terms of discomfort because the mask is more likely to fail, it's more likely to get air leaks, and anything you do to put a patient off CPAP therapy is another reason why you will fail. This is basically MADs as well, because the thing is, if you think about what I was saying earlier on, if the problem started off with the nose, if you did the nasal surgery and gave them a MAD as well, you would do something to try and equate the tissues forward in the tongue base, even if you don't want to do tonsil surgery or palatal surgery, you just want to do the nasal. Why not do nasal, try a MAD, and see if it improves things further. I think we should insist as a specialist that nobody else is really trained or experienced in examining the airway. We are more than welcome to be part of an MDT, but we should have our role as well. Sharing with your chest physician, your max fax, or even your dentist is not a bad idea. If you don't examine the patient properly, that's poor medical practice. You're going to end up with rubbish results. There's also potential medical legal complications. If you look at some of the flights that go to the anesthetists now, if they get into a situation where you can't intubate, can't ventilate on an OSA patient, you get shacked. You absolutely have no defense. They advise them to do a stop bang on every patient crib. If the stop bang is elevated, insist on having a sleep study. We should follow the same principles. We're the ones who operate on the upper airway. Slightly large chap. If you're not vigilant, inadvertently you can have a fatality. I've had experience where an inexperienced anesthetist gave a patient morphine on the table. They had a respiratory arrest on the ward. It's about knowledge and your experience and caution. As of this April, you are funded in the NHS for MDT clinics. So if you've got a local service, approach whoever's in charge of that. So I'd like to join in, I'd like to help you out. Share the pie. It's fully funded, so there'll be no reason why they can't actually incorporate you to that clinic. I'm concerned for the younger generation of SBLs coming off the conveyor belt. It may not be a job for you. So you better find something that you can do that is well paid. And actually, emotionally, this is one of the most rewarding areas to be in. You can so transform people's lives. I mean, compared to any surgical procedures I've seen, actually to change somebody's life dramatically for the rest of their life is an emotionally rewarding thing to do. It's also good sense, it's good medicine, and it's good business.
Mike.